So just to start off, perhaps, what is Zika? Dr. Lucy, could you perhaps provide some color? What is Zika? What does it cause? Just for everyone that's unfamiliar. Is that okay?
Sure. Yeah, thank you. And thank you very much to the organizers for letting me be here and to share the stage with the three distinguished panelists besides myself. So Zika is a virus, not a bacteria. It's a flavivirus, so it's the same family of viruses as viruses like dengue, West Nile virus, yellow fever virus. Flavy just means yellow in Latin, I think. Fortunately, obviously there's good news and bad news, and the good news is for most people who get infection with Zika virus, they don't have any symptoms at all. And those who do, which is less than 50%, they're mild and they go away within 7 days. And what they are is mild fever, much less than with dengue, joint pains, but much less than chikungunya, some muscle aches, some red eyes, but not nearly as bad as Ebola, and some rash. And the distinguishing thing really about clinically, in my opinion, and I say this from having visited Brazil February 9th to 16th, talked with clinicians, is that the rash is itchy. That's very different than a lot of rashes due to infectious diseases. So it can help with making the diagnosis. So the rash you might get with dengue is certainly not itchy. Of course, the bad news and why we're here, I think, is because of what the Zika virus, in my opinion, it's now been established. There's room for discussion, and I welcome other comments by panelists. I think Zika virus does cause microcephaly, as Jay said, so small head, small head. But why is the head small? Because the underlying brain is small, because it's been severely damaged, because the normal brain size hasn't occurred. And when I was in Brazil, I saw really striking, very memorable, hard to forget, can't forget images of brain scans of about 15 children with Zika-related microcephaly. So the brain damage can be very extensive, not just to the upper part of the so-called cortex, but also to subcortical areas like the thalamus and the cerebellum. So let me stop there.
Thank you. So we've heard about microcephaly, but where is this actually occurring? Should we care about this in DC? Does this influence us in any form? Dr. Indigo, perhaps you could provide some information.
That's one of the handouts I did not make copies of, but there is at cdc.gov, you can continually check to see where reports are being made for the Zika virus. I do have it in here. It is, we're gearing up for summertime when mosquitoes come out. Of course, it depends on the range of this particular type of mosquito. One of the things, my work with climate change, we're seeing increases in things like Lyme disease because of the range, the conditions being hospitable to vectors. And so we don't know yet if this has anything to do with climate change, and I'm looking at the experts next to me. I would assume it does. But for the time being, there are no cases reported in the district, but we are seeing, we are having concerns, and there have been cases reported that have come, people who have traveled to foreign countries with the Zika virus have come to the United States, and we don't have any that have emanated from the States as of yesterday on the CDC website. So please go ahead.
Can I, this is actually, I'm going to go ahead and break your nice rhythm that you're establishing by pointing to and asking my fellow panelists who know way more about this than I do. There was a really nice, to me, paper that came out in PLOS Tuesday, 16th of March, no, Wednesday. I lost a day to St. Patrick's Day this week. I'm still very confused. That came out on Wednesday that attempted to model the, looking at 50 urban areas in the US and looking at the range of Aedes species, looking at mosquito density, looking at 10 years of temperature projections, and then looking at poverty levels in those cities as a proxy indicator for the ability of people to educate themselves and protect themselves from the virus, to try to create a risk profile for each of those cities over the next year. And I thought it was a very interesting modeling approach, trying to give policymakers something that was technically based but accessible, to understand which cities were likely to be at risk because of tourist traffic, because of poverty levels, because of climate, and because of the competent mosquito vector being present. And I don't know if you've seen the paper or not, but I think it's a very interesting way to approach it. It's Monahan et al.
Oh, really?
So maybe I can make a couple comments here, particularly about the vector, so following up kind of on both of your points. So the mosquito that is presumed to be the most important vector is a species called Aedes aegypti. This is the yellow fever mosquito, and it's such an efficient vector in part because it typically occurs in close association with human habitation, so they will breed in habitats like water cisterns that are left out to collect water, but also the water that collects in flower pots, or even something like a bottle cap that gets left out, collects water. Sometimes females will lay their eggs in containers as small as that. Now, Aedes aegypti does occur in the US, but it's restricted to southern portions of the country. So really from about Jacksonville, Florida, south along the Florida Peninsula, and then also along the Gulf Coast. And this is in part because this mosquito doesn't have a hibernation response, and so it's not able to survive a temperate winter. However, there's recently a report of a population of Aedes aegypti that appears to be established in the Capitol Hill neighborhood of Washington, D.C. And so there's speculation that somehow these mosquitoes have adapted to using some kind of underground hibernacularium or some other underground habitat to make it through the winter. So that's a little bit disconcerting. The other issue to keep in mind is that a closely related species, Aedes albopictus, has also been documented as being capable of transmitting the virus. This mosquito does have a very robust overwintering response and occurs in the eastern US from the Gulf Coast and Florida up to about northern New Jersey. And in fact is one of the most abundant human-biting mosquitoes in the Washington, D.C. area. So I think there is concern that although there's been a lot of focus on Aedes aegypti as a vector, that in the US, Aedes albopictus could play a role in transmitting the virus. And just one quick comment to follow up on your issue about kind of socioeconomic factors and how that could affect exposure to the virus. So we did a study in Washington, D.C. I mean, one of the amazing things about Washington is you have neighborhoods of dramatically different socioeconomic status in very close proximity. And we actually did a study in DC where we went out to neighborhoods of different socioeconomic status and would ask people to go into their backyards and look at the types of mosquito habitat that we found. And one of the things we found is that in the lower socioeconomic status neighborhoods, so places like Deanwood and Trinidad, you do find a lot more what we refer to as kind of non-permanent habitat. So things like small containers, trash buckets that are left out. And in higher socioeconomic status neighborhoods like Georgetown, you see that you find mosquitoes in more permanent fixtures, things like bird baths, rain gutters. And so the overall mosquito abundance didn't differ between the neighborhoods, but Aedes albopictus is much more likely to inhabit these containers that we found in low socioeconomic status neighborhoods. And so, the inference would be that, yeah, some of these areas might be at more risk from receiving bites by species like Aedes albopictus.
So I quickly looked at my sheet that indicates that every state in the United States has at least one case of Zika. They're all travel associated. There are 3 in the DC area. Knowing now what I know about the mosquitoes, that could be problematic from a public health perspective. As the weather gets warmer and people are returning from other countries and are infected and they get bit, and then that will spread, of course. to folks who haven't traveled, and so it might create a problem.
Thank you. So there's also talk of other forms of transmission. Could someone perhaps speak of, there are controversies over the sexual transmission. What do you guys think of that? Is that valid?
Absolutely.
Please.
Yeah. So there are handouts, black and white handouts, and also a color handout at the desk. They have found that Zika can live in semen for longer than it can in blood. I won't read off what this sheet says, but they're recommending men who live in the countries of concern where Zika is epidemic, and for those men who are traveling and coming back, that they wear condoms. This is for both vaginal and anal intercourse, and they're not quite sure yet about oral, but they're also recommending that men wear condoms for oral intercourse as well. And the thing to know with Zika is that you get the symptoms, as Dr. Lucy said, they're, just kind of whatever, nondescript. People don't really think they're sick. This Zika virus has been found, was transmitted through vaginal intercourse by a man who hadn't even had symptoms yet. So it was before the symptoms came out. So it is very real. It is very much concern. I'm sure we're going to talk at some point about the Pope's statement about birth control.
Yes, absolutely. So that brings us to two primary junctions. We can battle Zika on the 80s front and also on this, the seminal front, if you will, or that. What are the implications from Zika being transmitted through semen? Like, a lot of governments around the world are actually offering or proposing different ways to curb the spread through semen. So you mentioned the condom use. Some countries are also advising their populations to just stop, having families. What are your thoughts on that? Like, is that just? Is that ethical?
I think that there's a question about the ethical aspects. There's also just a question about the practical aspects of this. And this is not the only virus that's transmitted. Obviously, sexually is not the only virus that's a vector-borne disease. This is not the first time as a species we've encountered viruses that caused what appeared to be a relatively mild clinical syndrome, but turned out to have potentially profound effects on developing fetuses. So you guys are way too young to remember, but rubella virus used to cause periodic epidemics. The estimate during the worst of those epidemics in the US during the time that disease surveillance information was actually, people were aware of and collecting information. After it became clear that rubella has the potential to cause profound birth defects. That discovery was made in 1942. There was a major US outbreak of rubella virus in 1962, late 50s, early 60s.
That's what I was going to say.
Yeah.
Around there.
The estimate at the peak was that about 1% of pregnant women who were infected with rubella gave birth to a child that had mild to severe birth defects. And it was the peak susceptibility was during the first trimester of pregnancy. So this isn't the first time we've confronted something like this. We seem to collectively, we confront every problem afresh with short attention spans and short recall of the ethical debates and moral debates that happened in this very vein 60 years ago, 70 years ago. I think there's an ethical question and a practical question. The risk communications around this particular epidemic have been difficult because there have been so many unknowns, and because in terms of risk perception as a species, there are lots of very good studies that are published that show how differently we perceive risks we think we can control and that we can't control, and risks to ourselves as adults versus risks to children who are vulnerable and perceived as unable to protect themselves. And those are even more amplified when you talk about babies, which is a very emotional issue fraught with moral and ethical norms as well, and religious overtones. So this is a really complicated issue. We have, on one hand, we do have a track record we could go back to, how we've responded to other events that were like this. The societal adaptations, the messages we inculcated into the health professions, the ethical professions at that point. On the other hand, this is really complicated. The risk communications have been difficult. And advice from decision makers to entire populations, maybe you should just not have children for the next 2 years. It's not a particularly practical piece of advice, particularly because in many of the countries where those announcements have been made, women have very limited choices about contraception and about controlling reproduction. So some of the advice has been pitched poorly, some of it has been simply difficult to follow. And I do worry from the perspective of health messaging that when you give a population a piece of advice that is both difficult to follow and frightening, you actually erode some of their empowerment and decision-making capability rather than enhancing it.
Jay, I'm going to ask you to pass this around. There's an excellent article, a story of a young woman who became pregnant, and particularly in Brazil, there's an awful lot of poverty. And just to build on what you just mentioned, the messaging has to be really customized for the group that you're speaking to. And it's very common in the poor neighborhoods in Brazil for women to get pregnant in their teens. And this particular story is quite poignant because it talks through the very difficult decision-making and worrying that goes on. Peter talked about the need to get rid of the excess water that's in tires and such, and many of those families don't have screens on their windows. It's great to say use air conditioning if you can afford it and you actually have windows that close. And so that whole idea of telling women just don't get pregnant, I worked actually for many, many years in family planning. Just say no doesn't work, and so for a lot of reasons. And so I think back on Ebola and the level of stress that went up as we were working through that crisis, and think that it's very important for us, particularly in the public health community, to help folks know, okay, your husband just traveled back from Brazil, got some mosquito bites, or maybe not even, for the next few weeks, just be sure you use a condom, okay? It's a little more tangible when you're living in those countries where babies are being born and you're seeing the babies with microcephaly and you're wondering if your baby is the one, right? And so there's no simple answer to this, and I think that women have to be empowered to make those decisions. There's been other stories written about mothers who are quite happy despite the baby being born with these disabilities. It's going to be a struggle, it's difficult, but to just tell everybody not to have babies is unrealistic, honestly.
And we find that some women are actually moving from Central America or Latin America to Florida just to have birth. There were many articles in the New York Times, Wall Street Journal about people that have the means to move for 9 months perhaps. Just move, have your baby, and come back. Definitely not viable for most of the people in South America. But moving onwards, how can we deal with this on the mosquito front? How are we trying to fight Zika on that front?
Sure. Well, a couple thoughts. So maybe as a little bit of context, so Aedes aegypti is a mosquito that's originally from Africa, and it was basically spread all across the world starting in the 1500s in association with the slave trade. Aedes aegypti has been eliminated from Brazil previously. So in the 50s, they were able to eradicate this species, and they did so basically by using a military-style campaign to eliminate the habitats of the mosquitoes, and also by spraying DDT. And of course, that has a whole nother set of kind of environmental implications. But it's important to note that it has been done successfully before. I think now the strategies being used are a lot of insecticide spraying, attempts to eliminate the breeding habitat, although probably not as organized and extensive as they were in the 50s. And there are also new approaches based on the release of genetically modified mosquitoes that we've started to hear a lot about. So this is an approach, the kind of leading approach is being implemented by this company, Oxitec, and they've developed a strain that is genetically modified such that all the individuals carry dominant lethal genes. So you might ask yourself, well, how does that work, right? When they die, if they carry a dominant lethal? The thing is that this dominant lethal is repressible, so you can rear these mosquitoes in the lab under the presence of tetracycline, and the effect of the dominant gene is repressed. Then you release males, so the idea here is you can't release females because they're going to bite people. You release males, and what the males are better than humans at doing is finding female mosquitoes, right? One of the reasons it's so hard to get rid of Aedes aegypti is that they use such a wide variety of container types that you just basically can't get to them all, right? But the male mosquitoes are actually pretty good at finding female mosquitoes. So these genetically modified males mate with wild females. All the offspring inherit the dominant lethal. And another attractive feature of this approach is that the dominant lethal doesn't kick in until they've completed their larval development. So these offspring that are destined to die still grow up in the larval habitats, and as a result they suppress the natural populations by competing for resources. So it's a clever idea, and in field trials, which have been of fairly limited scope, they've shown that they can actually, this approach, releasing these males, can suppress the natural populations pretty dramatically. I think the caveats to keep in mind are that these field trials have been over very small areas, and even to do this over very small areas, you've got to release tens of thousands of male mosquitoes a week. It turns out the males don't move very far, and so you've got to really saturate an area with these released males. And so it's not really clear how feasible it's going to be to scale up these efforts to protect a large city, and certainly on the scale of, thinking about broadly across South America. I just think it's very unrealistic to think that it's going to be possible to scale this up at a huge level. The other issue to think about is, well, how much mosquito suppression do you need to reduce disease transmission, right? And so we have some models that suggest that something like 80% suppression might be sufficient to reduce transmission, but that's still a little bit of an unknown. So I guess I guess the take-home message is that spraying is an important component of efforts to control this thing. Habitat, getting rid of the larval habitats is also really important. These genetic approaches might contribute, but they will be just as part of an integrated strategy that includes all of these approaches. Does that make sense?
Yeah.
So you mentioned the field trials. Where are these being tested? You said very limited. Have they been across, just concentrated in one area?
So there was one release in the Cayman Islands, and there's been one project that I'm aware of feasibility. So yeah, I think it's really important.
That brings us to a good point. When we had Ebola was massive. There were companies working on drugs, but then Ebola evaporated from our conscience. Do you think the same will happen with Zika? You mentioned it may take a while for, we have this month public comment period. Then there's a matter of drug testing and manufacturing. Do you anticipate the same result for Zika, or do you think it's different? Anyone?
Julie, please. If you're talking, I'll just go on too long.
No, I'll just get started. I mean, I think that it's It's a really interesting question, right? So there's a lot of you can compare the Ebola virus disease outbreak in West Africa and the slow spread of Zika, which has now hit our consciousness as the extent of spread has become apparent. And it's partly become apparent to us so suddenly because most of the disease is mild and self-limited. So no one realized how geographically extensively the disease had spread since 2007 in the outbreak in French Polynesia until the Brazil noting of microcephaly increased cases, which again is really hard to tell. Not that it doesn't appear that there's a biologically plausible link, but the baseline data is terrible, the case definition is inconsistent. There's just so much we don't know we didn't know. So where that gets us to is how health threats emerge in the public consciousness, how we perceive those threats, how we react to them. So I think that there's going to be a lot of differences with Ebola virus in that when the Ebola virus outbreak was first noted and reported by the Ministry of Health in Guinea in March of 2014, it took 6 months, well, it took 5 months to get the World Health Organization Director General to convene her committee of experts to determine whether or not an outbreak that had already caused thousands of cases and thousands of deaths at that point was a public health emergency of international concern. It took from March until late August. In September, the grinding gears of the UN began turning and countries began offering assistance, technical assistance and financial assistance that was massive once it was offered. But it took 6 months from the time that the catastrophe was noted as being imminent to the time that there was real coordinated global response. Vaccines that were already in preclinical trials were rushed through the regulatory process in a safe and reasoned way, but accelerated into development and trials. And then as you said, although the outbreak has still not stopped, it is slowed tremendously. It is not yet over. As the number of cases decreased on a daily basis and the use of the experimental vaccines to actually interrupt transmission became less critical, the political will to really carry that vaccine development forward on an accelerated basis and see real vaccine not just tested for safety and efficacy, but actually taken into development and manufactured and approved and licensed and made available for preventive use. The political will has died. The political will has slowed because people in the US and in Europe are no longer perceive themselves as being at risk. There's still a need for the vaccine. It has been carried forward. There probably will be manufacture of some doses at some point. But the will to do it has really greatly diminished. I think it will be interesting with Zika to see if we get into year 1, year 2 of this outbreak across the world before there is an approved vaccine candidate licensed for use as a preventive vaccine, what happens to the will? I think that will still be there. We vaccinate for rubella. We can afford that vaccine. So I think there will be something carried forward. It will be tested. It will be used. I do think an interesting parallel, though, is West Nile virus, which we seem to have forgotten about completely, which appeared in the U.S. in 1999. First cases reported in 1999, and it went from 6 counties in New York in 1999 to basically the entire continental United States by the end of 2003. And again, we forget, it causes death. People die from West Nile virus in the U.S., hundreds every year. I think the total is about 1,800 since 1999, I can't remember. But mostly it's old people that die. So we're not quite so incensed to worry about that. So I do think that there's an interesting parallel. Personally, I think there will be a licensed Zika vaccine, probably 2 or 3, for use in Western Europe and the US in the next few years. The question is whether it happens quickly enough and whether there's a political imperative once we're less scared to keep with the development process and make an affordable vaccine that can be used by the people who are at highest risk globally.
Do you have some thoughts? I saw you.
Anyone else? No, go right ahead.
So this is a topic very near and dear to my heart, both Ebola and now Zika. And I agree with everything that Professor Fisher just said. Nearly everything. So for me, from working with a lot of patients, 200 patients with Ebola disease, and mostly in Liberia, but with Doctors Without Borders in October, November, but before that in Sierra Leone in August 2014, I was very, very struck by the inadequate international and national response, including the U.S. response. And what that meant in terms of suffering and death. Immediately, many more people died of Ebola in West Africa, in Sierra Leone, Guinea, and Liberia than due to Ebola, but they died because of Ebola, because the hospitals were closed, because you couldn't get treatment for typhoid, for malaria, for TB, for HIV, you couldn't be treated for complicated pregnancy because there's no place to get help, the hospitals are closed. And 900 healthcare workers in West Africa were infected with the Ebola virus, 900. 512 died. Those are the ones we know of. How many healthcare workers in America died of Ebola? How many healthcare workers in America have ever died of Ebola? 0. So there's a lot of concern here, and that's a separate issue. But it's because of working in West Africa that, with Ebola patients, that for me, although it never occurred to me to say anything, if you will, or to write anything, with regard to the WHO Director General, Dr. Chan's delay, I think unconscionable delay between March 23rd, 2014 and August 8th of 2014, when the lab confirmation of Ebola was first made and announced in a lab in France on the blood of a patient from Guinea, a former French colony, and when Dr. Chan finally convened the emergency committee in August. It never occurred to me to write an op-ed, which the post wouldn't have taken, but I could have at least felt better writing it, or done something, writing a medical journal or something. But once I became aware of Zika in December, I didn't do the right thing. I didn't get on the plane. This is what I did. I go out, get on a plane and go to the place to understand what's going on. Is it really an epidemic or not? Reasons that Professor Fisher mentioned are true. But for me, going there and talking to the doctors who first discovered the epidemic, because they've worked in the same place, same hospital for 20 years, or in this case, her mother also was a doctor there, and she's still working. So they normally see 3, 4, 5 cases of microcephaly a year. Now they've seen 3, 4, 5. Her mother saw 7 in one day. So that, to me, that's an epidemic. You don't know what it's due to. You test for the known causes. They're all negative, so it's due to something else. It doesn't mean it's Zika, but I think it is Zika. There may be some cofactors. So for me, I didn't get on a plane in December and go to Brazil. But by early January, for me, it became imperative to write something or have something published about, and that's what this paper is, from January 27th, the Journal of American Medical Association. So I wrote it with a very esteemed colleague who otherwise it would have been published, because he's got a very good connection with the Journal of American Medical Association, and they did the fastest review on a Saturday, Sunday, submitted Saturday, accepted Sunday, which I said, really? So normally it takes 6 weeks, 8 weeks, 3 months, and even then they wouldn't have accepted it from me. But for me, it was all about the last section. It's titled World Health Organization Leadership, and it's 4 paragraphs. And this was the reason for writing the paper. This is what I wrote originally. All the rest is very nice, very important, but for me, it's not worth writing the paper, but Professor Gaston thought otherwise, and I agree. He said, we have to write everything else in order to give the message at the end. And he's wiser than me, and so it got published. And what it says, and some of you I'm sure are familiar with it, but basically we said, I'm just quoting, an emergency committee should be convened immediately to advise the Director General, Dr. Chan, and it's got to be convened by Dr. Chan. She's the only person in the world that's empowered, and I'd say who has a responsibility, frankly, particularly after the horrendous disaster of Ebola, which to some extent, it's the virus that did it, but Dr. Chan failed to convene the committee, which then galvanized international support immediately for the outbreak. So I wanted to do the same thing I wanted her to do the same thing with Zika. And so the paper was published on the 27th. Dr. Gaston has a lot of connections with the media. He did many, many, many interviews, and I did some. And I think it wasn't coincidental that the next day, which happened to be the 1 week of the year when the World Health Organization Executive Board meets, and they were meeting that week, the next day Dr. Chan announced that the following Monday, February 1st, she would convene the committee. The committee convened. The director is Dr. David Heyman. He and 11 co-members of the committee, wrote a paper in The Lancet, published online February 10th, in print February 20th, describing the meeting, which that's never been done before. And they said they were only contacted on Thursday, the 28th of January. When they met, the first ballot, if you will, was unanimous that microcephaly, possibly linked to Zika, should be declared a public health emergency of national concern. So I think a lot of good things have happened. A lot of good things happened before that in Brazil and by the Pan American Health Organization and by the U.S. CDC and even the White House, but not from WHO. But good things have happened since February 1st.
That's awesome. I didn't do absolutely anything except observe history collecting, but I was actually in Brazil when they confirmed the first Zika case. We were at a meeting at the Ministry of Health, a PAHO meeting at the Ministry of Health.
In May?
Yeah.
Yeah.
And I think that one of the things that was immediately noticed was PAHO immediately went into action. It wasn't a delayed, like, what should we do? There was an immediate, this is an urgent event. And it wasn't that they had, shock troops to go parachute into Brazil to isolate the mosquitoes and wrestle them to the ground. But they immediately, PAHO immediately recognized this was something that required a coordinated response and information sharing. And they had the information out to the other PAHO states like the same day, the next day. There was communication covered.
And just emphasize, you said Zika and you meant Zika. Long before microcephaly was. It's really admirable, in my opinion. I didn't interrupt, but I just want to emphasize, this is Zika that doesn't cause much disease normally, except in the fetus. So that's really admirable. And I'd say that probably did the same thing with microcephaly, if not possibly even faster. So Brazil, PAHO, U.S. government, and I'm not always positive about the U.S. government, but I think they've done tremendous good with regard to Zika microcephaly. And I would start to call it out the Zika microcephaly neurologic disorders spectrum, or if you want the word syndrome, or because some adults do get a paralyzing disease called Guillain-Barré. And in fact, a few people, it's been reported now in the medical literature, can get an infection of the brain or the spinal cord. Very, very rare, just like the Guillain-Barré, very rare. It happens. The viruses we call neurotropic. And we knew that from the late 40s, early 50s in mice. But it's true in humans as well. So, Joanna, I'm sorry to cut you off. I didn't mean that. I just wanted to emphasize when you were talking about Zika, that's really, really admirable, I think, on the part of PAHO from last May. And you're right, they produced these documents on their website, and they continue to do that about Zika. And then since at least December 1st on the PAHO website about the Zika link with microcephaly.
Just one of the on-the-ground effectiveness, PAHO had put together these little cards. So when I got off the plane, there was somebody passing these cards out, front and back, with it, information about Zika, how to protect yourself, that it had been, the week I landed was the week they found the first case in St. Thomas. And so I thought it was somebody just, trying to sell us something. All right, whatever. And it was very, very well done. So PAHO came through very well.
Thank you. There was actually a study published on Tuesday in The Lancet that said only 1% of Zika infections cause microcephaly. Dr. Lucy, how do you reconcile that with what you saw in Brazil and where you've been?
So I'm a big proponent of time and place, or time and space. So the study you're referring to in The Lancet wasn't from Brazil, it was from French Polynesia.
Okay.
I think that, yes. And French Polynesia has a population of about 270,000 people, 66% of whom it's estimated got infected with Zika when the Zika epidemic occurred in French Polynesia between September and maybe October of 2013 and around March of 2014. And again, hardly anybody gets sick from that. In retrospect, they did have 42 cases approximately of Guillain-Barré, but that's a small percentage of 2/3 of 270,000. And they didn't recognize the congenital neurological abnormalities, the children born with congenital abnormalities probably linked to Zika, or the 8 children born with microcephaly. They normally have 0 to 2 children with microcephaly per year on the Polynesian Islands. It's only because of Brazil announcing on the 11th of November a national, quite a lot of detail, 2 pages, and
Wow.
it took